It's a great pleasure and honor for me today to be with two giants in the field of interventional cardiology. And we're going to be focusing today on interventional issues in cancer patients, primarily looking at cancer patients with ACS presentations. So I'm very lucky today to be joined by Dr. Deepak Bhatt, as well as Dr. Cezar Iliescu, neither of whom need any much introduction. So maybe if I start with you, Cezar, talking about your experiences with cardio-oncology patients when they really present, the cancer patients with acute coronary syndromes, and your experiences in this area.
So thank you for the kind invitation, and I'm really privileged to have Deepak here with me, who, as you said, is a giant in the field. We started in 2008 when I was recruited at MD Anderson to run the first cath lab in a cancer center in the world and to open this field of intervention in cancer patients. Before that, the approach was the patients with cancer were mainly treated by the oncologist. The focus was on the cancer care, and the cardiovascular care came second, maybe after the cancer treatment is completed. So it basically put the cancer patients in a situation where exactly in the midst of the fight, when they're septic, thrombocytopenic, anemic, tachycardic, to have on top of the underlying disease and the complications related to treatment, acute coronary syndrome. That is why it's very, very difficult to triage and challenge and get in the middle of this fight exactly when the patient is weakest, most frail. So early we understood what the challenges are. So first question was, should we do these patients and can we do them? And the can we do was the first issue we had. We started doing them in a systematic way. I was a surgeon before that. So the first thing you feel is a patient a good substrate? Is a patient who's going to have a chance to live? And we've realized there was a little confusion about the septic patients with positive troponin and abnormal cardiac biomarkers. They were called acute coronary syndrome. We had a lot of Takotsubo. We had a lot of myocarditis that inappropriately we were calling acute coronary syndrome. Once we started doing this early invasive strategy, we went inside, we did angiograms, we did LV-grams, we did biopsies, we did all the complete workup. We did the OCT intracoronary, we saw ulcerative plaques. So we're able to assign the events and categorize them appropriate and treat appropriate. Why we felt that is relevant is because one is Takotsubo, one is myocarditis treatment, and one is acute coronary syndrome, where in a patient with thrombocytopenia, you have to escalate the antiplatelet anticoagulation treatments. And of course, the risk balance, it changes throughout. So that was the first thing we understood really early. The second thing we understood is the way they assign the events, the mortality. Of course, everybody dies from cardiovascular diseases. Cardiovascular complications were the norm for all these patients. When we started delving into the way the events were assigned, we realized, patients were relapsed, refractory disease, and they're transitioning to hospice, So that patient is not a cardiac arrest. That's not a complication procedure related. Again, we have patients in ICU, septic, with pHs in the 6, 9, 7, with abnormal EKGs, and in the end, they spill troponins, high sensitive troponin. Of course, that's not a cardiac event. The cardiac condition is not driving this cardiovascular, the death of these patients. So I think this is one of the biggest challenges we had. Once we understood that and we started working on it, we were surprised to find that, really we can do these procedures. We started again with the thrombocytopenic patients with low platelets, radial access. We did this, Deepak, you were there, 1, 2, 3 we're doing for diagnostic. So 1 of Lido, 2 of nicardipine, and 3,000 of heparin. And we're surprised to get ACTs therapeutic with 3,000 of heparin, which would have translated in 30, 50 units per kg, so half dose. So that's how we came up with, maybe half dose in patients with thrombocytopenia, less than 50,000 will help us and allow us to do these procedures. Then, of course, as we started moving forward, the next question was, what antiplatelet regimen are you comfortable with in a patient with thrombocytopenia? And surprisingly enough, we started, of course, as pure cardiology as we could with the aspirin and clopidogrel at that time, and we were surprised to get good results. We used, again, the stents we thought they have the fastest stent healing at the time, and you saw the evolving field. We moved from, 3-6 months to really now a month and 2 weeks almost in a lot of platforms. So again, we always thought about abbreviating course of DAPT, We tried to do a lot of IFR, FFR, and by that we decreased the number of lesions. We stented by 50% consistent. So we just stented what we had to. And again, we always image on the way out, post-dilatation, very pure cardiology, aspirate and flush every catheter exchange. And the results were really very, very good. We look back and almost the mortality and morbidity related to our cardiovascular complication is nothing. So once we look back, we understood that basically the biggest driver of all these things is really the cancer. In good hands, accurate, meticulous access, pure cardiology, as solid as we can do it, the outcomes are driven by cancer. And then the way was, how can you look at this large data? We're so used in cardiovascular literature. We have our traditional cardiovascular risk factors, and then we have one variable we're looking at and see if that impacts the outcomes. And out of a sudden, we have the cancer patient population, which everything is personalized from markers, stage, treatments. So out of a sudden, it's very, very challenging to say how we're going to be able to do real research the way we understand in cardiovascular literature on the cancer patient population. To an extent, after all these years of doing it, and the weight that cancer has in the overall mortality of these patients, and the small to almost nothing mortality and morbidity we bring with our procedures these days, to an extent, like the variables are all cancer variables that are driving the process, and us, we're almost like, do we put a stent or not? And that is very, very interesting and intriguing to me, and was through all these years, because it was all this cycle that we had to go through from our traditional approach to cardiovascular research in cancer patient population to where we're cancer patient research with a cardiovascular spin, where we just basically are the variable, just a stent or not, antiplatelet regimen or not, and we're really not driving a lot of complications, mortality, morbidity, actually is mainly cancer driven. The more we look, the more we understand, and Deepak is going to go in the data and everything, is obviously a patient who has a solid tumor and we put him on antiplatelet regimen is going to bleed more. So the question is, how can we be active and use shorter DAPTs, choose the right moment when we revascularize the patient, postpone as much as we can the intervention and the escalation of antiplatelet regimens to where it is a comfortable moment. We have a short, stable interval of 2-4 weeks where DAPT is possible without dramatic bleeding, and then revascularize. So all this sophistication has to be brought in the field. But I do believe, and I'm going to pass the baton to Deepak, I think that there's this beauty about small data and large data, be able to merge them and implicate them. And we're privileged as well to work with Mamas and with you, hopefully in the future, to basically merge these two approaches where this very meticulous granular things that we have from our patient population, they can be extrapolated in large data. Because in fairness, I do not believe we are ever going to have the traditional cardiovascular trials that we have for two reasons. One of them is the oncology field is exploding. The speed they change treatment and they move is, to an extent, by the time we get an RB, the standard of care is new for the cancer patients. Us as well, we're privileged, to see this explosion of newer platforms with shorter DAPTs, there's new changes in paradigms and everything. So by the time we really crystallize a project and we're ready to push it in, the things are already old. So I do believe maybe when things are going to get more stable, we're going to be able to do like more proper and traditional cardiovascular research. But right now, I think that the future is going to be for this kind of research is to be able to use small, registries, groups, maybe national registries with more sophistication related to the cancer treatments, and then merge them with the large cardiovascular data.
Thanks so much, Cezar. So I think you've touched upon some of the practical implications about dual antiplatelet therapy, duration of therapy, thrombocytopenia, and maybe I'll come back to you with those issues, but you also raised upon the use of registries, larger data sets, maybe national data sets. And I know that Deepak, you have published recently in this space, and you've really looked at the larger picture, the bigger data, and very interesting findings in terms of mortality and the approach to patients in the primary PCI setting when they come in with cancer. So maybe if you could just give the listeners some ideas of your research in this regard.
Absolutely. Well, thank you, first of all, for having me. And it was really a privilege to just be able to hear Cezar's comments. He's been such a leader in this field, even before it was a hot area. Of course, now cardio-oncology is an extremely hot area. The fellows all want to go into cardio-oncology. It's booming in terms of different centers opening up. areas that focus on these patients, but really as an early pioneer, I'd congratulate you on all you've contributed to the field, and thank you for those contributions. So before getting into the specific of what you just asked, Arjun, in terms of the registries and analyses, I'm going to step back and take an even bigger picture. I mean, cardio-oncology is just really booming. There's just lots of patients that are surviving with cancer. I think, especially for older physicians, they might think back to when they were in medical school, things like lung cancer, colon cancer, renal cancer, pancreatic cancer. These had just horrible prognoses. You wouldn't really be worried about cardiovascular prevention, let alone intervention in these patients, because their projected lifespan was so low. But times have really changed over the past few decades, where there are very effective therapeutics now that aren't always necessarily curative in the case of solid malignancies, but at least do extend the time that patients are able to live, and even live with good quality of life. So lots of advances there. But as a consequence, we really do need to think about cardiovascular disease in these patients, because they're living longer, and also proportion of the treatments, chemotherapeutics, biologics, certainly radiation, can increase the risk of various cardiovascular disorders. And we've got to think broadly. It can result in valvular heart disease, can result in myocarditis. Where I am at Brigham and Women's Hospital, we're the cardiologists for Dana-Farber, so we see a lot of pericardial effusions coming in. Some weekends on call, there'll be more tamponade than there are just conventional STEMI. So really need to be prepared as cardiologists, and not just interventional cardiologists, to deal with what will be a very predictable influx of patients who have survived cancer or are being treated for cancer. Having said that, now to get into the specifics of what we're really discussing, I'll mention the paper that you were alluding to. This is a paper that came out in European Heart Journal, Acute Cardiovascular Care, a bit earlier this year, and examined one of these really large databases, the National Inpatient Sample. And it's, there were over 1 million patients, almost 2 million patients with ST elevation MI that we examined. And it turned out that about 2% or so of them had a diagnosis of current cancer. And of that, so it's not a trivial amount. So we're not talking about just a rare thing. Now we're talking about patients with STEMI. How many have that? Active cancer, 2%. So again, this isn't some rare bird we're talking about. And of those cancers, about 28% or so were hematologic, about 12% or so were breast cancer, about 25% or so were lung cancer, about 10% or so were colon cancer, about a quarter were prostate cancer. So a mix of different types of malignancies. And first, what we found was that these patients that had cancer received primary PCI significantly less frequently than those without cancer. And it varied a bit depending on the type of cancer, just to give you a range in this study. The patients that were in the sample were from 2004 to 2015. So things might have changed a little bit since that time, but I think the core findings would still hold if we repeated it in 2021. But about half the patients with lung cancer with STEMI were getting primary PCI, about 70% of those with hematologic malignancies, compared with 82% of those with no cancer. So you can see a bit of a gradient there of underutilization of primary PCI in people with cancer. But beyond that message of underutilization, which I think is an important message, there's also the message of outcomes. Now, obviously, this wasn't a randomized clinical trial. I think it'd be very logistically difficult to do a randomized clinical trial of primary PCI versus no primary PCI in STEMI in patients with active cancer. I'm also not sure it would be ethical if such a trial could be designed, but therefore this isn't randomized, but we did a bunch of fancy statistics here, propensity matching and so forth, and some sophisticated analyses. The first author here was Dr. Mohammed. Dr. Mamas was the senior author, but some very fancy statistics. And what we found with that in observational data was a lower associated rate of major adverse cardiovascular and cerebrovascular events, and also lower all-cause mortality in the patients, all of these patients now we're talking about with active cancer, who were treated with primary PCI. And in fact, it was similar to the rates of outcomes in those without cancer. So in the context of observational data, with that caveat that it's not randomized, it certainly suggests that in the patients with active cancer who were selected by the operator to undergo primary PCI, the outcomes weren't as horrific as perhaps as some physicians might have assumed. In fact, they're as good as the ones in patients without cancer. Now, obviously, there are other medical issues that might affect the longer-term prognosis, but at least, in terms of that decision of should the patient with active cancer with a STEMI go to the cath lab or not, I think this is almost always the case. In patients presenting with STEMI, going to the cath lab is generally the right thing to do. Of course, common sense has to be used. If somebody is, in hospice, DNR, metastatic cancer to the brain, completely debilitated, it may not be appropriate. But for folks that aren't in that sort of situation, really something to more strongly consider, and not just sort of be biased against cancer patients to say, oh, that patient has cancer or even metastatic cancer. Therefore, even though they're coming in with a STEMI, I'm just going to, medically manage it. And even the patients on hospice, it's sometimes the case that hospice, status will and can be reversed. It depends on the particular situation. Obviously, the goal there is comfort and palliation, but a STEMI can be rather painful. So it really requires a lot of thought. And in the case of STEMI, it's thinking on the fly. That you don't have hours to really think about those decisions. So there's got to be some quick decisions made. But at least now there's some data on a macro level showing that it is not a crazy thing to take patients with active cancer with STEMI to the cath lab. And in fact, I would say in the majority of those patients with good clinical wisdom, it's the right thing to do.
Great, thanks so much. So I think this is something that definitely I've seen in my own clinical experience, especially earlier on as a registrar, as a trainee. When you give the history, somebody comes in with the STEMI cancer, automatically, patients are, oh, well, what's the stage and all of these things. And as you say, a lot of the patients nowadays, cancer actually, we're not talking about terminal disease in months or years, and progressively, patients on immunotherapy, newer therapies can be surviving for quite a period of time. So, a question maybe to you, Cezar, given, from the practical side, how best can we change the mindset? Because I appreciate that the data that Deepak just mentioned is not immediately contemporary. It is from a few years back, if I'm not mistaken, the data sets. So in 2021 today, if a patient comes in, how can we convince the interventional cardiologist to take the patients to the lab? And could I ask, is the problem with the interventional cardiologist, or is the problem in the emergency department or with the oncologist, that they are the ones who are maybe saying, well, this is the situation? Maybe if I start with you, Cezar, and then move to you, Deepak.
Beautiful question, Arjun. So it is a process. First of all, it's a process and it's an issue of trust. So what we started is, as Deepak alluded to, very, very conservative. We just did only appropriate things. You do STEMIs, you do acute coronary syndrome, real things. And then again, we're trying, the field was initially of the oncology community is that we're going to get busy on the oncology patients. And we're going to put all these stents, and we're going to have this extensive course of DAPT. They will delay all the cancer treatments. And early on, we've established really like the axioms, the fundamental things that we have to do for this patient population. And one of them is, again, one is do not delay the cancer milestones, the treatment. So basically, we call the oncologists and we ask them, when do you need to put the patient back on treatment? And if they say tonight, then again, we have to make a decision, a collective decision, but it's not unusual to send that patient in the morning and again, start the treatment at night. And we have a nice paper, it was in IJC, where we resumed cancer treatment as fast as we could, with the understanding that someone is going to absorb some additional risk, and was us. So we knew we were going to absorb this additional risk of the procedure done in the morning and resume the cancer treatment in the night. But the patient, they did it, and they did well, actually, very well. But again, meticulous procedure, post-dilatation on the way out, image on the way out, make sure we have no issues. And if we have no issues, really, we let the patient get treated. The second one was good news for the cardiology community. We thought initially that the cancer patients will have delayed stent healing. And, it makes sense. We know we had some animal models, and we worked with Jorg and Dr. Marmagiolis and other folks, about the stent healing process. And surprising to us, the stent in cancer patients heal as well as in general population. Okay, there may be some delays, but not significant enough to translate in different outcomes. Why is that happening? Is because I think the overall performance of the patient does not deteriorate in the 2 to 4 weeks we need now with the new platforms to heal. So basically, if we look at a patient that's viable, and then as Deepak said, it's not hospice, it's not going, and it's not terminal, that patient is good enough, then we'll heal as fast as the other patients. So the general overall increased frailty and all the other things we all know about them, low albumin and everything may not translate in delayed healing. So our OCT data suggested that really the stents and the new stent platforms heal as well. So we're really excited to see that this contemporary cardiology allows us to really negotiate with the oncology team. Is it 2 weeks, 4 weeks? Again, very seldom we end by doing bypass because we're looking at probably 6 to 2 month delay, 6 weeks to 2 months delay. And that is not acceptable for a cancer patient population. Sure. I actually discussed with our lead oncologist and asked him, he says, where's this data coming from? Where's the data, the 2 months delay in cancer treatment translating different outcomes? And he laughed and he said, only a cardiologist could have asked that question. Because the reality is they cannot afford any delay. So if it's cancer, you wish you were treated yesterday. Yeah. So that's why I do believe that the PCIs in this cancer patient population are to be done. Yeah. I think that probably a good cardiovascular assessment initially is the way to go. So you do not get into the middle of the fight exactly when the patient is too sick to get treated. Sure. I think you have to be cognizant and do it with understanding that we do not want to do delay. We do not want to modify the cancer timelines because their most important driver of the survivorship is the cancer and not us. I do remember when I talked to Dan Lenihan, who recruited me with Dr. Ye many years ago, and he asked me, he says, when you go in the oncology field, do you understand, Cesar, you're not going to be the prima donna? So the oncologist is driving the show and you're supporting team. And are you okay with that? And it was difficult because I was trained as a surgeon. So, we used to be flashy and we try to show off. So it's very, very difficult to accept that in this show, the oncologist is running the team. He's making the final decision. He's the final chef in the kitchen and you're the first assistant, which is probably the most important assistant, because I think that the cardiovascular status is the main driver of it. And with that understanding, we gained that trust. We've created these good collaborations. We have no issues, honestly, Arjun, in the ER with the oncology teams. And we've established this faith where we do, and we have seen that we do everything on everybody. Sure. To the extreme, we did stenting in platelets 4. We did cardiosynthesis in patients with platelets 4, 5, and we have no limits. But again, with the understanding that, all these patients are sicker, worse, and we have to negotiate. So this discussion, getting them involved, communication is key. Yeah. And I think this will expand the field. And with all this enthusiasm and more people in the community, taught in big centers and spreading this word about how we're doing it, will help.
Okay, so I guess basically a lot of communication is important and education and getting the better outcomes. So I think if the patient comes in and then they have the stent, there is always the concern with readmission and what's happening in the next 30 days or 60 days. So I think Deepak, this is another area where you've published it and you have some data as to what happens in the readmission rates and what happens after the stent is put in. So maybe if you could shed some light on this bit.
Yeah, absolutely. There was, first of all, I've got to say a lot of wisdom just in terms of what Cesar was just saying, really lots of pearls for the audience listening. And the oncologists are typically driving the ship here appropriately so. And patients certainly don't want to have their cancer care delayed. There's the medical reasons, but there's also just the psychosocial reasons. It's a stressful thing and treatment needs to be started promptly. And if revascularization is needed in general, PCI would be strongly preferred, of course. The need for collaboration is also quite enormous. That's true with the initial care and decisions, and it's especially true with the subsequent care of these patients. And along those lines, while I just made the point that there is underutilization of PCI for STEMI based on that analysis in EHJ-CVP, there's also the flip side of, well, not really flip side, complementary side of the underutilization of PCI in general. So in the EHJ, acute cardiovascular care article I mentioned, that was just STEMI, but really it extends to NSTEMI and folks that have really disabling angina where, if it's otherwise appropriate to treat them, the cancer shouldn't be used sort of as a bias reason not to do what would otherwise be medically appropriate. But, using common sense and, being honest that the risks might be higher. So that's true on the front end. It's also true on the back end. And the next paper I'm going to mention is one in EHJ. The first author was Chun-Shing Kwok, and the senior author was Dr. Mamas again. And what we did here was look at a different large database, the US nationwide readmission database. Once again, very large overall sample, almost 2 million patients that were included. And we looked at those with active cancer, which is about 2.7% of this particular population. So similar to the other ones, around 2 to 3% with active cancer. And just parenthetically, I'll mention about 7% had a previous history of cancer, but that's not going to be the focus of what I'm going to say now. So I'm going to really focus on the ones with active cancer versus no cancer. And the readmission rates after AMI, the PCI combos were higher in those with active cancer. And this is not that surprising, I suppose. The readmission rates were also higher after PCI. Again, not surprising because a number of these patients will have thrombocytopenia, anemia, other tendencies towards bleeding. But just to be aware that these patients perhaps need even closer follow-up. There needs to be greater vigilance on the part of all their different treating physicians and on the part of the patient, their families themselves. So this shouldn't be used as a reason not to otherwise do appropriate PCI in the context of myocardial infarction. And as I just alluded to before, in fact, the issue is underutilization here, not overutilization, but there does need to be an awareness that there's a higher rate of potential ischemic and bleeding complications. And those are things that to some extent can be modified. The bleeding part in particular, Cezar alluded to some pearls earlier on, but just want to be careful about different things. So, I'm a big believer in intense dual antiplatelet therapy and extended duration dual antiplatelet therapy. But, one does have to employ common sense in general in practice, and especially in these sorts of patients, many of whom do have bleeding diatheses, and they probably want to use the shortest duration of DAP that you can get away with. And for some patients, that'll just be a month, which with current generation drug-eluting stents certainly seems appropriate. There are lots of registry studies and even some modest-sized trials that show that with contemporary stents, that a month you can certainly get away with as far as DAP duration. But some technical things to consider too. I think in doing these sorts of procedures in patients where DAP is going to be abbreviated, in this case, we're talking about folks with active cancer, but even other situations, maybe where patients have a bleeding diathesis or recent bleeding, there I think it probably does help to optimize the stent deployment. I think, can't likely hurt using adjunctive imaging in that setting, IVUS or OCT or dealer's choice, whatever that particular operator is comfortable with, optimize the stent diameter, its apposition, and that would, I think, decrease the risk of stent thrombosis, and therefore at least that aspect and contribution of DAP, reducing stent thrombosis, becomes less critical after that first month or so of DAP. So, things like that are useful. If there's an increased risk of GI bleeding in that patient with active cancer, or even without active cancer, if they've got a high risk of GI bleeding, consider proton pump inhibitors, caution patients about the GI bleeding risks of NSAIDs. In general, patients should use NSAIDs for the shortest duration and dose possible, but especially if they're on dual antiplatelet therapy and additionally have bleeding diatheses, those are patients, if possible, to really minimize or steer away from NSAIDs. In terms of bleeding risk procedurally, of course, in this situation and others, radial would have some advantages over femoral. So assuming that the operator and lab are comfortable with radial approaches, I think that should probably be the default unless there's some particular vascular access issue. And, if radial doesn't work, there's always the other radial, there's ulnar. So, there's ultrasound assisted vascular access that can be useful. So I think there's a number of things that really need to be done. Perhaps they should be done for all patients, but that thinking should be even more crystallized in this patient with active cancer, where we know that the risk of badness is higher. And some of that risk isn't going to be things that we can reduce, but some of it we can address.
Sure. Thank you. So I think we're coming towards the end of this very fascinating discussion that I've had, and really looking at some of the practical tips from Deepak and from Cezar on how to manage these patients in the lab itself, as also looking at some of the larger picture, as Deepak alluded to, for cardio-oncology in general, and how we should change our mindsets maybe as cardiologists in managing cancer patients, knowing that a lot of these have some form of chronic disease rather than an acute or time-limited disease. So I guess just like to end it with asking both Cezar and Deepak for their last thoughts on how best we can get our interventional and other general cardiology colleagues to be managing these patients. So maybe Cezar, your parting thoughts for this group of doctors.
So I do believe it is an exciting field. I think that as cancer treatment have evolved and all these new things have reached the medical community, as well as the huge progress really with the stent platforms and really miniaturization of the access and cardiovascular interventions to where we really have minimal risk of bleeding and complications. I think this created an optimum moment for the cardio-oncology field. And I think that that's exactly what Deepak said. This is the moment to explode, because we have on both fields good results, and we're ready to tackle extremely complicated patients with extreme frailty and with really no plan B. And this is the understanding that the cardiologists have to accept. Is this patient very seldom we have a surgical procedure, surgical option that will delay cancer treatment to an extent we will lose the cancer patient. So you have to understand it has to be assigned in a good day with appropriate time, probably a little bit more time than the general patient, but still it's a patient that should be done. The survivorship we report right now in a cancer patient center is 66%. That means 2 out of 3 patients will be cancer survivors, which is dramatic. Every day we cut another cancer from the fatal to more better outcomes. So I do believe all this we're going to reach our community, and it's a process. And the beauty is, again, we have a lot of brilliant young heads that spread the word, and I think it's going to translate in this reaching our cardiology community. What's beautiful, and if you look at the data, and they talked about the antiplatelet regimen in patients with thrombocytopenia. Actually, the adapters are in the community. So in the community, they're more aggressive in using antiplatelet regimens in patients with decreased platelets, and not academic centers. So I think that it's a very interesting, and so people in the trenches, the private practice groups are really tackling these patients without fear, and they're treating them, which is really reassuring. And again, it's the job of academic centers to keep on coming and finding new avenues and new forms of transmitting this knowledge, if possible, and optimize the treatment of cancer patients.
Great, thanks so much, Cezar. And Deepak, if you have any last words for our colleagues, how best to manage and tackle this situation.
It's hard to top Cezar's wisdom there. I agree with everything that he just said. I guess I just say, I hope the topics we discussed are interesting to the audience. I do think, it's like many aspects of medicine, there's just some fundamental body of knowledge that's really good for all physicians to have. So it's like complex dyslipidemias or someone needing an LVAD, they're probably referral to a specialized center makes sense. And, something similar here, if, someone has accelerating angina and it's not an emergency, but it's an urgency, there it might make sense for their cardiovascular care to be at the same place where their oncologic care is occurring. Maybe for an NSTEMI that can be transferred, but is otherwise complex active cancer, thrombocytopenic, transfer to a referral center may be appropriate. But obviously, if someone comes in with a STEMI, most times that's not going to be possible. You've just got to deal with that primary PCI there. So I do think it'll be important for cardiologists in general to become more aware of cardio-oncology, even if that's not the focus of their practice, because it's going to be in their practice to some extent. But of course, as physicians, we should always have the humility to know, when it might be best to refer on. But certainly for emergency situations, there's got to be a skill set here that cardiologists are familiar with, whether it's, that patient presenting in tamponade or that STEMI coming in at midnight. An increasing proportion of patients are going to be cancer survivors. And therefore, in cardiology, we've got to be ready to provide the best care we can for these patients and not be sort of biased against them based on old data and old thinking and old learning that, oh, they've got cancer. They've got one foot in the grave, no need to be aggressive. Need to really modernize our thinking and understand that in many cases, cancer is a chronic illness that's going to have ups and downs and various therapies along the way. But cardiovascular disease is going to be part of the problems those patients face, and both from a prevention perspective, that's important too, and an intervention perspective in some of those patients, we've got to be willing to provide excellent care and not hold back simply because the word cancer is in their medical record. Sure,
thanks so much. I think many thanks to both you, Deepak, and to you, Cezar, for joining us today. And I'm sure that the insights you've given will be very interesting and educational for our viewers. Thanks so much.
Thank you.